Okay, so this is a fourth video about acid-base disorders, and this is kind of like acid-base disorders 101, sort of an introduction to them. And one thing to reiterate is some terminology. So remember, normal pH is between 7.35 and 7.45. If someone's pH is less than 7.35, we call that an acidemia, or we say they're acidemic. If the pH is above 7.45, that's alkalemia, or they are alkalemic. So I want to differentiate that from an acidosis and alkalosis. So these are disorders. So like they're disease states that want to push the pH into acidemia, for instance. And alkalosis is a disorder or state that wants to push the pH into alkalemia. Okay. In real life, compensation takes place, and we're going to get into that. And compensation wants to bring the pH back down to normal. It never brings it all the way to normal, but it's going to try and move it as close as it can to normal. It may end up right there, for instance. Like for alkalosis, compensation is going to kick in to try and bring the pH closer to the normal range, and it may stop right there. But acidosis and alkalosis are processes, they're disorders, where acidemia and alkalemia is what the pH actually is in the patient. For instance, you could have an acidosis and an alkalosis simultaneously and actually have a pH that's within the normal range, even though there are two separate disorders present. So understanding those differences is important. Okay, so now we're going to talk about some of these processes, but first I want to bring your attention to the Henderson-Hasselbalch equation. And remember that this is the pKa 6.1, but there's also this term after that, which is the log of the concentration of bicarbonate uh, divided by 0.03 times the partial pressure of CO2. The 0.03 is a term for how much of that CO2 is actually dissolved in aqueous solution. So what's important here is that the pH here is actually determined not by each of these things on their own, but more by their ratio. So the ratio between these two is what really determines the pH. So that any disturbance in one of these, the other would have to move in the same direction to keep the ratio the same in order to stabilize the pH. So keep that in mind as we go through some of these processes here. If one of these changes, the body's going to try and alter the other one so it's moving in the same direction so that the pH remains unchanged. And this is what we call compensation. So a metabolic acidosis. So this is an acidosis, and it's primarily a problem of addition of acid. So there's new hydrogen ion that was added, which corresponds to a drop in the amount of base. You could also have an acidosis from a primary loss of base in the urine, for instance, and then there's remaining hydrogen ions left behind. This is what would determine a metabolic acidosis. So based on what I just said about the Henderson-Hasselbalch equation, compensation for a metabolic acidosis, if this term has decreased in order to restore the pH, the PCO2 would have to decrease. And this is accomplished because the medulla recognizes a change in the pH and will stimulate the respiratory center and cause you to hyperventilate, to blow off CO2 to normalize the pH. Likewise, a metabolic alkalosis is when there's been a decrease in hydrogen ion. Likewise, a increase in bicarbonate. This can occur if there's renal loss of hydrogen ions that's excess more than expected, or accumulation of bicarbonate or buffer, or some sort of stimulus that's causing excessive bicarbonate reabsorption in the kidney. Those are things that maintain a metabolic alkalosis. Likewise, what would the respiratory center tell the lungs to do in this situation? Well, if bicarbonate levels are high, it would slow down respiration and slow down ventilation so that the PCO2 rises. This is called respiratory compensation for metabolic disorders. So, along the same vein, a respiratory acidosis is something that interferes with ventilation so that the PCO2 rises. Likewise, the way to compensate for that would be to increase the amount of bicarbonate. A respiratory alkalosis, so if someone's hyperventilating, they're going to drop their PCO2. Compensation for that is going to be reduction in bicarbonate. And mainly the metabolic compensation for respiratory disorders, acutely, it's mainly due to intracellular and some extracellular buffering. But over time, if this persists for a few days, it's really renal compensation for the respiratory process. But this big picture is something you should definitely understand and have committed to memory. So to build off that last section, we do know exactly how the compensation should go for each of these disorders. So first, for the metabolic processes, this equation tells us how ventilation changes in response to a metabolic acidosis. This is called the Winter's equation. And I do think it's very important. There aren't that many equations that you even need to memorize to be a doctor, but I think this, if I had to pick one, this is the one that I think every physician should memorize because it's so important, and metabolic acidosis is incredibly common in the clinical setting. So for someone who has a metabolic acidosis, remember they're going to hyperventilate, they're going to drop the PCO2, and this equation tells you exactly how much it should drop. So 1.5 times the serum bicarbonate plus 8 plus or minus 2. You know, there's a little fudge factor just because it's not perfect, but I would certainly commit this one to memory. For a metabolic alkalosis, we have a similar equation. I don't think it has a name attributed to any certain person, but this one, expected PCO2 is 0.7 times the serum bicarbonate plus 20. So for a metabolic alkalosis, PCO2 would rise because the bicarbonate has risen. For a metabolic acidosis, the PCO2 would fall because the bicarbonate has fallen. Remember, we're trying to keep those ratios the same in the Henderson-Hasselbalch equation. Okay, now we're going to talk about compensation for respiratory disorders. And this is the way I organize the information in my head, and it's a way that helps me memorize it. And by the time we're done, I hope you'll see that. So let's just do them one at a time. So an acute respiratory acidosis. So ventilation is acutely decreased and the PCO2 is rising. So in response to that, what would the bicarbonate do? It would rise. So the bicarbonate's going to rise a slight amount. And remember, this kind of links back to one of the other videos, but as PCO2 is elevated, there's going to be more carbonic acid produced. That is going to be buffered somewhat intracellularly by red blood cells. Some of those hydrogen ions are going to be buffered by hemoglobin. Some of it's going to be exchanged intracellularly for intracellular potassium, for instance. And so in response, there's a little bicarbonate that's left over. So the bicarbonate will rise a little bit. So the bicarbonate will rise by 1. And this is, 1 per 10 millimeter mercury increase, okay, in the PCO2. Okay. So for a chronic respiratory acidosis, it's not done by cellular buffering. By this time, the kidneys have kicked in, and they're contributing. So they're able to do a lot more work. And the buffering here is about 3 to 4 milliequivalents per 10 millimeter mercury increase in the PCO2. Okay. Compensation for a chronic respiratory acidosis would be uh, a rise in the serum bicarbonate, if I didn't say that earlier. Like I said, for an acute respiratory acidosis, it would be a rise in the bicarbonate. Okay, so for an acute respiratory alkalosis, so this is someone hyperventilating acutely, so this would be a decrease in the bicarbonate for every 10 millimeters of mercury decrease in the PCO2, right? Because in alkalosis, a respiratory alkalosis would be a decrease in the PCO2. In this case, it drops about 2 for every 10. This occurs basically because the whole carbonic acid reaction is being moved to the right to uh, produce more CO2. So as you reel off all that CO2, more bicarbonate and hydrogen ions are going to combine to make more CO2, and that will cause a measurable reduction in serum bicarbonate levels. So for a chronic respiratory alkalosis, um, we will see a decrease in the serum bicarbonate by about 5 milliequivalents for every 10 millimeters of mercury decrease in the PCO2. And like I said, this is due to a renal compensation. In this process here, to go from acute to chronic, we're talking about really, days. So these compensation rules are listed in a lot of textbooks, and as a student and resident, I always found it hard to memorize. But the reason I chose to think of it like this, number one, it separates it by process, whereas these are the kind of cellular uh, buffering processes, and then the chronic processes are the renal compensation processes. Um, the other thing that I enjoy is the numbers. I always found it hard to memorize the numbers, and so when I organize it like this, I just think count to 5. So 1, 2, 3, 4, 5. So if I can just count to 5, I can usually remember this. But you're probably saying, well, how do you know how to order these things on the left? And the way I remember that is just to think about alphabetical. So acute acidosis. So acidosis comes alphabetically before alkalosis, and the acutes come before the chronics. So as long as I order these alphabetically, and then I count to 5, 1, 2, 3, 4, 5, um, then I can remember this on the fly. And as far as what direction things are going, well, you should probably be able to figure that out just by knowing what a respiratory acidosis will cause the PCO2 to move and what that compensation would look like. So I hope this makes it easier to remember. There is a sort of a subtopic within metabolic acidosis that we have to mention since we're here. It's called the anion gap, and basically the anion gap is this little box right here. So what is this box exactly? So for those of you who haven't done much clinical time yet, we order lots of blood tests usually for hospitalized patients, and the blood tests come with, especially the basic metabolic panel. It includes a sodium chloride, a bicarbonate, a potassium, and those are the main electrolytes it checks. The anion gap is this idea that all the anions in the blood have to equal all the cations. So the cations are positively charged, the anions are negatively charged. They all have to be equal to one another to satisfy electroneutrality. But we don't measure every single one of these. The major ones that we measure, I just mentioned. And so the anion gap is sort of all of the stuff that's left over. We measure sodium, we measure bicarbonate, okay, and we measure chloride. But we don't measure is the stuff in here usually. So this includes phosphate, sulfate, some proteins, albumin contributes somewhat to the anion gap. These are basically solutes that have negative charges that we just don't routinely measure because it'd be really expensive and not very helpful. So you calculate the anion gap by just saying the amount of sodium minus the chloride minus the bicarbonate. And so the normal anion gap is about 10 or 12 milliequivalents per liter. Okay, so what if I added new acid to a person? So HA represents the new acid, so in solution, this would disassociate, right, to hydrogen ion and some organic anion. When this occurs clinically, so the hydrogen ion is buffered by bicarbonate. Remember, as we've discussed in other videos, that will lead to CO2, um, and then that can be ventilated off to help buffer this addition of the acid. But we also produce this anion that now has nowhere to go, and this will expand the anion gap right here. For instance, as the acid was added, look, the bicarbonate dropped from 25 to 15, and the anion gap went from 10 to 20. And so clinically, this occurs when there was the addition of new acid. So um, there are all sorts of mnemonics, but I like the easiest one, kill you, keto acids, ingestions, lactic acidosis, and quote unquote uremia, but renal failure can cause accumulation of new organic acid. So I use kill you to help remember the differential for new acid production in the blood. So we would call this an anion gap metabolic acidosis. Okay, so I do want to contrast that anion gap metabolic acidosis to a normal gap metabolic acidosis, and this would be a situation that causes a reduction in bicarbonate. So look, bicarb's 15 compared to 25, but that does not involve expansion of the anion gap. And so this usually occurs if there's some sort of GI loss of bicarbonate, or if the kidney is not able to excrete hydrogen ions for whatever reason. This usually results in a normal gap metabolic acidosis, because as the bicarbonate falls, chloride is retained, and so the anion gap is not expanded. The main reason for recognizing this up front, this distinction, one is that it's easy to calculate on a basic metabolic panel, and number two, it completely changes your differential diagnosis. So that's why it's worth bringing up. Okay, so real briefly, just because it's pertinent to what we're talking about, I'll go over a quick approach to acid-base disorders. Something similar to this should be in any physiology or renal textbook and many online resources. So just find the one that works for you and the one that you enjoy. But I think it is important to kind of have a stepwise process for how you work through acid-base problems, because they can be kind of complicated in the real world. One thing that you're going to realize is that there may be multiple disorders. You could have up to 3, but hopefully in most cases you'll be able to pick them out. So here's the approach to an acid-base disorder. The main thing, you want to look at the pH to determine, is it an acidemia or an alkalemia. Okay, so this would be pH higher than 7.45 and an acidemia if it's less than 7.35. Once you've looked at the pH, basically determine what the primary disturbance is, whether it's a respiratory process, one that affects the PCO2, or is it a metabolic process, one that's affecting the serum bicarbonate level. For instance, metabolic acidosis would have a low pH, right? It would also have a low bicarbonate, and you would expect, if that's the only thing going on, it would have a low PCO2 based on compensation. One kind of general rule, if these are all kind of primary, easy problems, metabolic processes, all the numbers go in the same direction. So the pH is high, the bicarbonate should be high, and the PCO2 would be high. If it's metabolic acidosis, all 3 numbers are low. But respiratory disorders, the pH and the other 2 variables move in opposite directions. So that's kind of a quick, easy, kind of from the door guess at what's going on. Once you've determined the primary disturbance, now it's time to calculate the compensation. And that's why we spend a little time on how to calculate compensation, because really the question you're really asking is there a second disorder present? For instance, someone could have a metabolic acidosis, but they could also have a respiratory acidosis on top of that. So what you want to do, let's say for a metabolic acidosis, you calculate what the expected PCO2 is with Winter's equation. If it is exactly what you calculated, then you're done. But if the PCO2 is higher than what you calculated, then you would say that that person has a secondary process, a respiratory acidosis. So there's a ventilatory defect and they're not able to breathe off the CO2 that they should be breathing off. That's really what we're doing when we calculate compensation. And you can do that with all of the main primary disorders. Here's a little caveat. So if you think there's a primary metabolic acidosis occurring, so I put the main parameters here, check the anion gap, and that's easy to calculate. Remember, it's just the sodium minus the chloride minus the bicarbonate, okay? And that will give you a number. Normal is about 10 to 12, but one thing to remember is that you should correct for albumin if someone has hypoalbuminemia. So a patient's normal anion gap drops about 2.5 to 3 milliequivalents for every 1 gram decrease in the serum albumin. So someone with hypoalbuminemia may have their normal anion gap may be 7 or 8. So a number above that would indicate an elevated anion gap. So after doing that, I put down here if the anion gap is elevated. So let's say you calculated it for someone it was 20 and normal is 10, so it's elevated. You can check this thing called the delta-delta, and we recommend doing it. You're really just comparing the change in the anion gap compared to the change in the bicarbonate. So for that example I just gave, the change in the gap was 10, right? It changed by 10 to 20, so the delta gap would be 10. Under normal circumstances, if there was only an anion gap acidosis going on, you would expect about the bicarb would drop by 10, right? For every milliequivalent of acid added, it consumed about the same amount of bicarbonate. So you'd expect the bicarbonate to be reduced by 10. So if it went from 24 to 14, that would be a delta of 10, and these match up pretty good. So the delta here is 1, such that, think about it, if this bicarbonate, if it dropped more than the anion gap rose, so if this number was higher, this ratio would be less than 1. And so if that was the case, you actually have uncovered kind of a hidden normal gap metabolic acidosis. So there's another process going on. Similarly, what if this ratio was very small, right? So if the delta bicarbonate was like 2 and the gap went up by 10, then that would give a ratio of 5. So if there's a positive ratio, I mean a greater than 1, that would suggest you've uncovered a kind of a hidden metabolic alkalosis. So this is one of the methods you can do to double check for any hidden processes if someone has an anion gap metabolic acidosis. So these 5 steps should catch all acid-base disorders, and this is kind of a quick overview of how to approach it. All right.